Welcome. My name is Natasha Sherman, and I am your host. As you may know, recently I did a series of shows on the opioid epidemic in New Jersey, and we have interviewed recovering addicts, the mother who lost her child to drugs. We've interviewed attorneys who are looking to hold accountable pharma and doctors. And today my guests are from another perspective. So my first guest is retired Judge Barnett Hoffman. And Judge Hoffman sat in Middlesex County from 1981 to 2002. At the time of his retirement, he was the presiding criminal judge. He's also the founder of the Middlesex County Adult Substance Abuse Program. Welcome, Judge Hoffman.
Nice to be here. Thank you.
My other guest is someone that Judge Hoffman partnered with, and he is Ed Mann, who is a dedicated drug counselor who spent 30 years at Rutgers Behavioral Health Care and retired, and is now clinical director for the Center for Network Therapy, an ambulatory detox and withdrawal program. But I just want to say that you are a licensed social worker, a licensed drug and alcohol counselor, and you have a master's in addictions counseling. So clearly you have been steeped in this for many years. Welcome.
Thank you for having me.
So you started this program together, and that is the Adult Substance Abuse Program. Judge Hoffman, why don't you tell us a little bit about what that is and the inception of it?
Okay. I was a criminal court judge in a criminal section of Superior Court in Middlesex County for several years, and every judge takes their fair share of sentences, and of that fair share, you take your fair share of drug cases. It dawned on me finally somewhere around 1999, 2000, when the people who I was sentencing, they have a right to address their sentencer, a right of allocution. And to a person, they all said, "Judge, I need a program. I want a program." And the fact of the matter is, this group of people, they don't have insurance, and they don't have the money to go into a private program. So one day I said, I think I'll start my own program, which was kind of a bold move because I didn't know anything about starting a program. So I went to the jail, the Middlesex County Adult Correction Center, and I spoke to the warden, told him about it. He was very excited about it. And he said, look, if you start it, I'll give you a housing unit called a pod. Then I spoke with the Middlesex County freeholders, and they were excited about it, and they gave us some backing, some financial backing, which they give to this day. And then I just got a little luck. I saw a woman that I know who is a great philanthropist, a great community person, and I said, I need some money. And she says, give me a little bit. And seriously, about 2 weeks later, I got a check from Robert Wood Johnson Foundation for $100,000 to get started. And they funded us throughout the first 7 years. Then I realized that I really should find out how to run a drug program. And all these years that I've been hearing people speak, so many of them came up to me and said, you know, Ed Mann said this, Ed Mann said that, Ed Mann said this, Ed Mann said that. So I said, I got to find out who this Ed Mann guy is. So I found who he was, and I asked him to stop by and help develop the clinical end of the program, which he did. So in 2001, with Ed and I partnering on this, the program went up and running on October the 1st, 2001, with 7 men. Who I always used to call my 7 original astronauts. And they started, the program started out as, and still is, a 90-day program in the jail. And it's not a compulsory program, it's totally voluntary. Normally you have to be there for about 30 days before you can apply for the program. And the reason for that is, that's our way of detoxing people.
Right.
We don't have a fancy way to detox.
Right.
So they detox while waiting to get in the program. When they get in the program, it's a rolling admission. We now have a men's program and a women's program. We have a women's program probably for 10 years. Give or take.
Yeah.
So the men's program usually has about 15 to 20 people in it at any given time, and the women's program somewhat less. So they go in, it's a program modification program that Ed can talk about better than I can, and we've been in business since then. We have close to 1,100 graduates.
Wow.
And
Wow, that's pretty amazing. Ed, now I'm going to turn to you. So, I mean, that's pretty impressive, 1,100 graduates. So how do you define, so graduates is one step. How do you define success? Is there a follow-up? Is there, when they leave, because from everything I've heard, one and done typically doesn't work, like 90-day program, okay, nice, but what's after that?
Well, we've done yearly follow-ups and looking at whether they reoffended again, whether they are working, are they self-actualizing. So we look at the whole picture to see how well they've gotten comfortable with the community and utilize the assets in the community, and the fact that they come back and they become a part of our program, our alumni.
Wow.
Where they participate on an active basis. So pretty much we continue to follow them throughout the years, and a lot of them needed help with getting vocational training or getting into some educational institute. And we're the program that could very well speak to them at their period of abstinence.
Right.
And oftentimes the program has been 90 days, but we kept them longer than 90 days. So
Right.
depending on what the needs are, because I don't want anyone to think that it's just a cut 90-day.
Right.
It depends on what their needs are, and then we keep them longer. We've been able to keep them longer inside the Middlesex County Jail, which has been an asset.
Right.
Because usually when you have funding from the outside, when you have programs on the outside, 90 days is 90 days, and
Right.
that's what funding sources are willing to pay.
Yeah. So
So-
that's good. So any statistics on the recidivism rate?
Yes. We had some studies done by UMD and J. Rutgers, and we found that our recidivism rate a couple of years ago is about 16 points better than the national average. The national average,
That's significant.
unfortunately, is like 2/3 recidivate. Ours is substantially less than that. And just to pick up a little bit on what Ed said, when they finish the program, they're still in jail. It's not like you walk out the door. You're still in
Right.
jail. And a lot depends upon the plea agreement that they make with regard to their case. And they're told that they're in the program to help themselves, not their case.
Right.
And
So there's no promise of you'll get a lesser sentence.
not at all. We don't have that power to do it.
Okay.
But if they do well in the program, we let the sentencing judge know, the probation department know, how they did in the program. Now they can basically go to a couple of different places. They can go finish their time in jail and go out on the street and go into an IOP, an intensive outpatient program. They can go to a halfway house. And Ed has been the guy that's really taking care of
Yeah.
the placement. When he says that people have been in contact with the program, they've been in contact with him,
Right.
even after he left the program. And the other thing, unfortunately, is with all these mandatory sentences, a lot of them have to go to prison.
Right.
So, and then we are also a good feeder for drug court, which is different.
Right. So Ed, it takes a certain kind of dedication and even I would say a calling to do this kind of work. After all this many years, what is it? And I know there's no one size fits all. I mean, as I said, I've interviewed from every aspect, and there's no one size fits all, no one reason. It's like an octopus, And but is there any commonality to the opioid epidemic?
Well, I think that there are people that get used to feeling comfortable with sedating themselves. And as we well know, we don't function well without sleep. With opiates, that's what they do. They calm you down. And that's the functionality, because folks don't go in it trying to be addicted to the substance. Even with pain management, you see nowadays, they get used to the comfort of not feeling the pain. And so that the commonality is that it's a sedative-like drug that's very familiar to sleeping. And so why wouldn't folks want that when sleeping is very much a part of what we do every day and we can't function without it? So that's the commonality I see when folks are addicted to, per se, opiates, because it brings about a level of comfort. It numbs you. You know, you have less to think about, less to worry about. That's the commonality that I see.
I'm going to ask you kind of a philosophical question, and there's no right answer, of course, but it's like this, what you've seen, you know, you've been in courts for many, many years. What is it about us, and this is something new, that has us seek comfort over just dealing with life or dealing with challenges?
Well, I don't know if I'm qualified to answer that question, but that doesn't mean I don't have an opinion.
Yes, that's what we want.
The new breed of opiate addicted people are a different group than we've had before.
Very much so.
These are people, for the most part, who were being treated by physicians for certain physical ailments. And because the doctors are now being monitored closely about how much medication they dispense, it comes to a point where they can't get medicine to help their pain legitimately. So what they do is they turn to street drugs like heroin and become addicted to heroin, which is very addictive. But we've been treating opiate, well, I have trouble with that, opiate addicted people for years. They just haven't been the type of people that are now getting addicted who people care about much more.
Okay, so in the past it was just, you know, I interviewed the former chief of police of West Long Branch, whose son overdosed, but they were, thank God, able to bring him back with Narcan. And I said, you know, so as chief of police, before this happened to your son, you probably thought that they were just a bunch of those people. He said, yes, scumbags, you know, that's kind of the thing. Except now, it's really, it impacts, and that's kind of, you know, a judgmental kind of a thing, but that we have these attitudes, and it's those people, it's over there, except now it's over here, and over here, and over here.
That's right.
So, again, you know, for me, it's like, again, it's just asking for your opinion. Yes. So do the doctors play a role? Are you suggesting that they are too strictly monitored?
No, I'm not suggesting that. Every case stands on its own merits, and I have a lot of faith that doctors are doing what they think is right. I'm sure there's some in every field that abuse it, but for the most part, I think doctors deal with their patient on what they have to do. But they have to be careful now. They can't treat for long periods of time without a break. And their patients are now turning to other sources of getting a pain medication, which is in the form of heroin.
I'd like to speak to that.
Yes, please do.
We trained doctors when I worked at Rutgers they were going through a training of addictions. And they're doing that more now. I think historically, they didn't have that training. And so when they gave medications for anxiety that people were on for 10 years, they didn't look at that addictive pattern that was being created. I think now that in their training, and it should be mandated in every doctor's training, that you become an expert on addictions, to be able to look at it, to be able to look at the patterns and see how it's very different sometimes with folks that have mental health issues and pain issues. And very well just folks that become street addicts. They're becoming street addicts for a reason. Maybe they have developmental problems. Maybe they didn't get a chance to adjust well in life. Maybe there's a history of familial addiction that have come down throughout the years. There's several ways to look at this, and we have to look at all of it if we're going to address it.
I think so, yes. And you know, it's interesting because I kind of see a lot of sides of it. You know, I've been at the receiving end of someone just saying, yes, morphine, yes, Oxycontin, whatever.
Right.
And since I am knowledgeable enough, I question it and say no. And this is from a doctor, you know, and I just spoke to a physician 3 months ago, and this was in a networking situation. And he said, when you enter the hospital, if you're in pain, the immediate, you don't even have to see the emergency room doctor at that point, face to face, the immediate recommendation is either morphine or Dilaudid.
That's right.
And so, again, you know, it's like you're talking about looking at persons individually, and we're looking at systems that say, okay, this is the automatic. Now, this physician said if he's on call in the emergency room, he rescinds those orders, but most physicians don't do that.
Well, it's interesting you bring that up, because we have doctors from Robert Wood Johnson Medical School who visit our program on a regular basis. And
They do a rotation.
They do a rotation through our program. One of the problems that we have seen a while back is just what you were talking about. People coming into an emergency room and getting a drug with morphine in it. And a lot of those people, or a significant portion of those people, had been in recovery. And as soon as they took that, they're back on the skids without any doctor inquiring into whether or not they're in recovery, whether they have a morphine addiction.
And look at the impaired nurses. You know, and I've had nurses that have said to me, Ed, I didn't know I was going to become addicted. I got it from the doctor, and it was okay. These are nurses. So you imagine if they're nurses, they're in the medical field, they're supposed to know about medication, and they're not aware of the impact of continuous, you know, opiates. Scary.
And you know, even now that there is all this kind of attention being given to the opioid epidemic, I suspect that someone in that situation thinks that I'm not in that category. My doctor is giving me, so of course I'm going to take it. I think, and you know, I suggested this to the two attorneys I interviewed, and that we as individuals have to self-advocate and self-educate and question. And they kind of thought that that was an unreasonable kind of idea, that most people wouldn't do that. And I'm thinking, well, why wouldn't you? And, you know, I understand some people that have a language barrier. Some people don't have the, you know, reading skills to go online and do the research. But certainly, I think somewhere along the way, we need to be educated to stand up and be accountable and, you know, stand up for our own well-being.
And if we don't, this is going to be more than what it is at this point. This whole epidemic, as they say, it's gotten progressively worse over the years, as we can see. This opiate thing is not new. They made 18-month therapeutic communities back in the 60s for this opiate epidemic. And now they reduced the number of stays to 6 months in these long-term programs that they've had historically. These programs were made for opiate addicts. So this isn't anything new. I think they're going to have to redefine what the opiate addict looks like. And to be able, part of treatment is to make them aware of what's going on and be able to identify what's happening to them. If you don't do that, then there's no accountability. So it's almost like saying, like, don't educate them because they're not going to understand. Then there's no accountability without education.
Right.
Because they don't know the signs and symptoms as they affect that individual.
Yes.
But what you said before really hit what we try to teach, and Ed hit on it again, is that we try to teach them accountability.
Yes.
You got to be accountable. Everyone that comes in with a criminal case, I often thought, I'm going to go around the country when I retire and take down e pluribus unum in every courtroom and put up, it's never my fault. All right? It's going to be, someone along the line, they have to assume accountability.
Yes.
Yeah.
And that's one of the things we teach. One of the graduates of our program at a graduation said something that stayed with me. And that is that A.S.A.P is like the Home Depot of recovery. It's where you get the tools to handle your problem. It's not a cure-all, but you get the tools to work with.
Yeah, and A.S.A.P is the program we're talking about.
And that's right.
Yeah, A.S.A.P is the name of the program.
Yeah, and so then again, I was thinking, back whenever, the whole message of just say no. Clearly that message didn't work. Just say no to drugs, and this is what your brain looks like on drugs.
Yeah.
So they were, kind of cool ads, but everybody thinks, well, that doesn't refer to me.
That's right.
So is there any message that we're not making that could be more effective?
Well, I just think part of self-actualizing is taking better care of yourself and realizing when something's not working. Awareness, accountability, they all play a role in this. And what happens is people have been able to say, well, I didn't know.
Right.
And that doesn't get it anymore. It behooves you to know what's going on with you, what's going on with your children, what's going on in your community. And those are the answers right there. Yeah.
Yeah, and again, I'm kind of railing against the norm, but it's when I watch these, the other day I had to spend the day in bed, I wasn't feeling well, so I'm watching television, and so many ads on take a pill, take a pill, take a pill, take a pill.
That's our mentality.
Mm-hmm.
And so it's very easy to be kind of seduced into the idea of, and even like the advertisement about the dad who comes to his kids and say, I'm taking the day off because I'm sick. And they say, well, dads can't take a day off, take a pill. So he takes a pill, and now he, and again, that whole idea of not taking care of yourself, that all you need is a pill. And it kind of then translates itself and weaves into all those addictive pills as well.
It starts with perception, and that's what people don't work well with. How people perceive what's happening in their lives. We always talk about changing behavior. What about changing perception of what's going on and how people perceive themselves in their community and what they're doing? I think if we start with perception, we'll be better instead of going right straight to behavioral changes. No, what's going on in that thought process and what makes it that way? And how can we help you? How can we intervene, to help you change it or look at it in a different way? And that's what we have to start doing.
Yeah, and absolutely. It's like that saying, perception trumps reality.
You better believe it.
Yeah, and so, I was thinking recently I interviewed two men who were wrongfully convicted, and between the two of them spent 38 years in prison.
Right.
And the thing that we keep coming up with, and I've interviewed some before, is this idea that we all think that can't happen to me. But it happened,
That's right.
and it continues to happen. And unless we start paying attention and being accountable, taking responsibility for educating ourselves, and even then it can still happen to you, but starting to be less myopic about our lives.
That's right.
And really looking around at what's the pervasive thinking,
That's right.
and
It's
then
so
what
important.
am I buying into? Yes, Judge.
It's a tough thing to do. I mean, if you look at television, movies, it's an accepted kind of thing of using drugs
Yes.
until recently. But Ed, I'd like to talk about the concept of people, places, and things,
Okay.
which we talk about in the
Okay,
program.
let's do that.
I think that's part of your question.
Okay, when we talk about people, places, and things, right away people feel that, just ordinary people feel that they're a product of their environment. So if this is something that your environment allows and finds acceptable, how do you individuate? And I think that's what's important, and that's what I try to teach them when they get in treatment. How do you become your own person, within that environment? Because yes, the environment, you want to be with the norm, but you're a person within that. And so you have to look at what your needs are and how well you're beginning to fit in that norm. Because some people are very conflicted by that norm, but they don't know what to do. And that's where your education comes into play, to say, yes, you're in your environment. You don't have to be a product of your environment. You can individuate and be very much different, because there's different people that have stepped out of those environments that they thought influenced them in a negative way. Because I think when we talk about people, places, and things, in my own head, I'm a recovering person as well. In my own head, I just believe that I have to make those things suitable for me. And with ownership and accountability, that's what taught me to step out of my environment and step into the right places where I needed to be. And it takes some really down-to-earth counseling, and not just sending you to support groups, which are important. They're supposed to reinforce what you're getting out of treatment or what you're learning about yourself. The people, places, and things, that's been one of the issues that folks get stuck on nowadays as I look at it, because they feel that they have to be with certain people, they have to be in certain places, and they have to do certain things that associate them with drug use. And I say to them, you have to step out of that. And it's about being uncomfortable. And if you're looking for change, then you better look for the uncomfortable and change. And when I wanted change, and I've been clean 40 years, is that I had to step out and see and take a risk to see what was different for me. And I was willing to accept that at any means, because I'd been through a lot, especially with family history of substance abuse. It's hard to break out of that cycle, but you can, with a willingness.
You know, that's really so powerful, and we're almost out of time, but it's just, you know, that whole thing about we spend our lives trying to be accepted, but we throw ourselves under the bus in the process, and we keep doing that and doing that. And really, all we're really after is to individuate.
And you say that so profoundly, throw ourselves under the bus, because I had to come from under the bus to really get what I needed for me.
Yeah.
And I imagine other folks will have to do that in the same fashion.
And I agree.
Yeah.
You know, I'm a life coach, so for me, I tell my clients all the time, be willing to be uncomfortable. Greet the discomfort.
Yeah.
You know, it's like when you get a cut, you're uncomfortable, but it's a sign to do something.
Yeah.
To attend to it.
And especially when you say you're so uncomfortable, and I'll let you speak, Judge. Especially when you say you're so uncomfortable in this addiction now.
Yeah.
Okay, then that's an indicator that it's time to be uncomfortable for something that's going to be more positive for you. I'm sorry.
No, I was just going to say, as you're healing, it hurts.
Yeah.
Yes.
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 As you're healing, it hurts.
So we are at the end of our time. Thank you so much for coming. Thank you so much for the work that you do. You make a difference in society, clearly. You've taken a population that nobody typically cares about and committed yourselves to them. So thank you so much.
Thank you for having me.
Thanks for having us.
My name is Natasha Sherman. Thank you for joining us.